bipolar disorder, a mental illness that, according to the National Institute of Mental Health, affects 2.6% or 5.6 million people in America. And it's very, very stigmatized by people. Most of you have an image of somebody who's going from one extreme to another, just crazy mood swings. But honestly, what you should be thinking about is somebody more like me. Luckily, you guys have one of the 5.6 million here today to tell you about the causes, the treatments, and the types of bipolar that there are. So before I can tell you the different types there are, I have to tell you the two different ways that it affects people. And that's in depression and mania. As you can see here, there's a depressed brain versus a non-depressed brain. The not depressed brain has a lot more activity going on in it, because what depression does is it basically kind of shuts down your brain. It makes it so everything is a lot harder for you to do. You're more tired, you're fatigued. Some people have thoughts of suicide or things like that. It sucks. You're way down on the bottom. The next is mania. It's hard to find a picture of a manic brain, so here's an example of it. Mania is the exact opposite. You're bouncing off the walls, your thoughts are racing. Everything just goes so much faster. You do things that you didn't think that you normally do, such as Britney Spears shaving her head off in 2007. She later came out as bipolar in her book, I Am Britney Jean. So this is the exact opposite. It makes you go kind of crazy. You'll have delusions, you'll hear things. Some people, more extreme cases, will have times when they think that they're Jesus, so that they can fly, so they jump off of buildings because of it. So next, we have the types that there are. According to the DSM, there are 3 different types of categories that bipolar falls into. Bipolar 1, 2, or bipolar NOS, not otherwise specified. So bipolar 1 is the more extreme of it. So if you look here, this is a better example of what bipolar 1 would be. This is a normal person, this orange line, experiencing highs and lows. But with someone with bipolar 1, to be diagnosed you have to have really extreme mania. So the type of person that would be jumping off buildings, they think that they can fly. It's mania that you would have to be hospitalized for because you'd be hurt. And that lasts for about 7 days at the least. And the depression part of it lasts for about 2 weeks at the least. The next one is bipolar 2, which is a less severe form of it. So instead of extreme mania, you're hypomaniac, which is you're still not sleeping, your thoughts are still racing, but you're probably not going to get hurt. You'll do some stupid stuff, but nothing too bad. The last one is bipolar NOS, not otherwise specified. A lot of people don't see it as an actual disease because it's more of a catch-all. So there's more examples in the DMS about this instead of an actual diagnosis. So it would be rapid cycling, so going from one to another day to day, which would also be called cyclothymania, or hypomania or mania without the depression part of it. So you're just up and then you just go normal. Or if you have bipolar symptoms as part of something else, that would also categorize as bipolar NOS. And lastly, we move on to the treatment of bipolar. There are lots of different treatments for it, but the two I'm going to talk about today are medication and electroconvulsive therapy. So with medication, you have 4 different options, really. You have a mood stabilizer, which kind of, if you're feeling both of them, it brings you down to the middle. You have an antipsychotic, so if you're more manic, you're way up here more often. It brings you down so you don't have the psychotic symptoms of it. You have lithium, which is something that's more widely used. It's been used many, many years. It has a response rate of 70 to 80%, which is pretty good. It also reduces the risk of suicide 6-fold. So you're 6 times less likely to kill yourself if you're on lithium. Usually it's mixed with something else, so an antipsychotic, mood stabilizer, antidepressant, one of those. There's also anticonvulsants, which are more seizure medication, but some of them, very few of them, actually do work to treat it. but usually, like lithium, it's mixed with another type of medication. So next we have electroconvulsive therapy, which sounds terrifying and also kind of looks terrifying. Basically what they do is they have these two little stickers that go onto your head, and these little, I don't know what you would call them, they look like Shrek's antennas. What it does is it causes mini seizures in your brain to try to rewire what's going on in there. Carrie Fisher, also known as Princess Leia, she's bipolar, and in her book she said that she gets electroconvulsive therapy. She said that it feels like it breaks up the cement that's in her brain. So it's kind of, that's how it's supposed to work. So it kind of just tries to rewire everything going on in there. This isn't something that everyone gets. This is something that you get if you're a very extreme case and medication just does not work. You usually get 10 to 6 sessions. You go a couple times a week. It's supposed to clear it all out. So that's basically it. Now that you know a little more about bipolar, the ways that it affects people, and how it can be treated, hopefully you can come out of here with a better understanding and help other people learn about what this illness really is and how it affects the people that have it. Thank you.
All right, so Mike, I noticed that you made it back to us. Thank you for being here. A few comments for Dolly, please.
Great presentation, but you really sounded so stressed, and I know it might be because it's a personal case for you, but you did a really good job, and it's really good. I really consider something good, but try not to be too stressed, even though like, I know you might, but try next time to
All right. Phone calls coming in. All right. No, it's. I was really embarrassed yesterday. I was listening to speeches in class, and my stupid notification thing went off. I thought I'd turned the sound off. Very disruptive there.
Sorry again for being so late. My car was about to get towed, and I had to convince the people not to.
All right. Do you have a
I do not.
evaluation rubric? Okay, I'll have to put this aside for them. Yeah, if you've got hers, that won't lose you 5 points.
I will take it.
Well, come get it and put your name on it, and then hand it back to me with your outline.
Thank you.
All right. Well, it's always easy to say don't be nervous, but it's hard not to be nervous. And we're going to talk about anxiety issues and dealing with those things. I do agree that it's probably because the topic is a little personal to you, and you care about what's going on here when you're talking about that. So that's one of the things that maybe produces a little bit of extra anxiety. I liked your attention device. I like the definitions that you started with. I thought that there's a good justification with the statistic that you're presenting also, so that was solid. I think the preview needs to be a little bit more structured and complete. In the body of the speech, it's organized. I can tell there's a topical division of the subject matter that you're talking about. However, the transitions between those points often just feel like you're jamming it into the next gear and then moving to the next thing, and they need to be a little bit smoother and more polished as you're getting from point to point. I mean, I know that we're making a turn, but it's a very sudden turn, a sharp turn, and it needs to be, like I said, smoother. That's why they call them transitions, to let us get to that particular point. A lot of stuff on the definitions, which was fine. The supporting material, I know it sounds like most of the stuff is coming from that GSN, is it, that you were citing? And I think you need to give us a little bit more credibility on that. that. I know that it's an authoritative publication, but I also think you need to find some other information too to support the material. I like the visuals a lot. I thought for the most part you did a nice job kind of explaining a basic concept on depression versus not depressed. I thought that visual was very effective. The explanation of the range with the graph that you had was also effective. And the pictures that you showed, I mean, when you're trying to explain mania and how people behave, that's a pretty well-known example of something that somebody could say, well, how could somebody be going through this process? What are you talking about? And there's one that probably everybody has heard of, and it fits exactly into the category that you're talking about. So I thought that worked pretty well. I like the references to Carrie Fisher when you're talking about electroconvulsive therapy. I know that came from someplace, and that could be another one of those citations that you should be putting into your presentation. I thought your delivery was fine for the most part. I know that you were anxious, but I didn't think it was distracting. You are looking at us, you're speaking up, maybe rushing just a little bit. Maybe that's where the anxiety is, and then you can hear the tremor in your voice a bit, but that's just energy that's coming out. It's not something to be too worried about. That's something, if you went longer, if you had more time, you would probably come and smooth into that a little bit more. It's just it's that sudden rush of adrenaline when you're actually doing the speech that probably produces that result. No prescriptions for that.